is an assistant professor of behavioral health sciences at the University of Alaska Southeast. She holds advanced degrees in medicine and health sciences and is a nationally board certified health and wellness coach, as well as a member of the Motivational Interviewing network of trainers. And Sarah has also been contracting with the Northwest ATTC for about 2.5 years now, I believe. With that, I'll turn it over to her. And thank you so much, Sarah, for being with us today. We really appreciate your time.
Great. Well, thanks for having me. I'm really grateful for this opportunity. So, thank you to the ATTC, and thank you to all of you who are joining me, as I'm presuming you have very busy schedules. So, thank you for taking an hour and a half out of your day to be here. I do live in Juneau, Alaska, and I just like to acknowledge that the University of Alaska Southeast resides on the territories of the Akwán, Tataquan, and Sheetaquan on Lincoln and Nye, also known as Juneau, Ketchikan, in Sitka, Alaska. And these are adjacent to the ancestral homelands of the Tlingit, the Haida, and the Tsimshian people. So I'm really grateful to live on this beautiful land. If anybody's ever been here, it's gorgeous. All right, so I would love to know who's in my audience today. If you would, in the chat, just pop your name in, maybe where you're joining us from and the role that you have. And if you're feeling like it, how are you feeling today based on Taylor Swift? So don't feel obligated, but if you would, I'd love to see who's with me and how you're feeling. Great. We got some eights feeling love. Welcome, Rissa. Pure sound. Cool. Sixes, fives, feeling one. Yeah. Boise, awesome. Cool. Some Seattle's great. It's good to have people. I love to see where you're calling in from, and what you're doing. Wonderful. Oh, cool. Search. Yeah, I'm familiar with Search. Anchorage. Awesome. Well, feel free to keep plopping them in as I keep going, but thank you for sharing and again, welcome. So here's kind of our objectives for today. It's just a little glimpse of what we're going to be covering, especially how MI can be applied with people who experience co-occurring conditions. And my hope is that you find something that from here that's useful that you can apply in your own work with others and make it, meaningful in terms of honoring the wisdom and value that our clients and patients bring. And you will have access to all of my slides and the recording, so you can sit back and listen or participate as feels good to you. So first, I just want to start with a quick definition of a co-occurring disorder, and this is taken directly from SAMHSA. Basically, a co-occurring disorder refers to someone who has both a mental health disorder and a substance use disorder at the same time. And this can include any combination of at least two or more, substance use disorders or mental health disorders as they're, identified and kind of characterized in the DSM. The main thing here is that they're really common. So we often see people with a diagnosis such as, depression or bipolar disorder, PTSD, you name it. They often self-medicate with substances and they experience addiction. And in my opinion, if I'm thinking about a substance use disorder, they're always co-occurring disorders. It's very rare that a substance use disorder does not include some mental health challenge or trauma, either as the root cause or as a result of use. So they often coexist together. And when we are working in addiction, we should just expect to encounter some form of a mental health challenge. All right, so if those of you are not familiar with Slido, this I think is really fun. So you will scan this QR code or go to slido.com and enter in that number down here, and magically your answers will appear on my screen, and they're all anonymous. So hopefully that will give you an opportunity just to participate with that sense of safety. So I'm curious with the audience, what clinical challenges do you see most often when you're treating co-occurring disorders in outpatient settings? So what clinical challenges are you seeing most? Again, you can scan. Oh, I see somebody typing. Let's give you a minute or so, and magically it should appear. Assessment. Yeah, absolutely. Lack of access to behavioral health care. Yeah. Engagement. Hmm. Medication compliance. Yes. Lots of engagement. I think it gets bigger when we have more people saying that. Stigma. Yeah. Provider collaboration. Staying on track. Yeah. Compassion. Ooh, I just got a lot. Limited, probably time, the diagnoses, the substance use part, the care exclusion. Yeah. Meeting the needs of mental health without triggering more substances. Absolutely. Yeah. Well, thank you. Thank you for sharing all those. And I think you probably hit everything on the slide. And there's probably more that I have forgotten. So some of the challenges that we see in treating co-occurring condition is because, as you just mentioned, they're complex. People might fall through the cracks, and that could be because they get bounced between services. I know here in Alaska, I have to always be thinking about mistrust in the system. They might have side effects to their meds. They don't want to take them, or they might struggle with motivation. There might be cognitive impairments. Someone mentioned the stigmas. There can be barriers, housing, legal barriers, unemployment, high risk of relapse, suicide, self-harm. I mean, these things, there's a lot. There are many challenges that we encounter, and I imagine that many of you at some point have felt overwhelmed by this complexity. And I imagine our patients and clients have felt overwhelmed by this complexity as well. So, one strategy, and I hope this is why you came today, is to employ some of the skills, techniques, and just the relational aspects of MI. So, for those of you that aren't super familiar with MI, this definition comes out of our recent edition, MI4. So, MI is a particular way of talking with people about change and growth to strengthen their own motivation and commitment. And feel free to unmic or put it in the chat, but what word or words stand out to you? Word or words stand out to you? Growth. Yeah. Any other words that stand out? Strengthen, commitment. Absolutely. All those are important words. I also want to draw your attention to this little word here, little but powerful. So, a big part with MI is that we are not speaking at people or necessarily even to them, but with them. So, with MI, we ask particular questions, we listen with curiosity, and more importantly, maybe most importantly, we learn. So, we are not instilling any motivation in them or in that person. We're trying to evoke it from them in this place of curiosity and wanting to know who you are and what makes you tick, what's alive inside of you. We're really helping them discover their why. And if we keep them talking about this, about the reasons to change, research actually says, yeah, they're more likely to change because we can literally talk ourselves into anything. And so, what I'm going to share today is that we can create environments for our patients or clients to be receptive to this change process and explore this growth and help them feel motivated and committed to kind of move on this journey together. And we can't make anybody change or grow. We know that, but we can provide conditions. And so I'm just touching a little bit on MI. There's so much to it. If you haven't already guessed, I love it. I'm really excited about this. So I'd encourage you to take more classes, learn more about it. There's just a wealth there. There's also a wealth of evidence, I should say, research. I think we're up to over 2,500, scientific studies that support the efficacy of MI in, yeah, reducing substance use and other addictive behaviors, but also the practice and skill set of MI has applied to so many other areas, everything from health coaching and nutrition to couples therapy, working with vets. I mean, it is all over. So there's a lot of research out there. So same thing with Slido. I'd love to see in my audience, how familiar are you with MI? So same thing, totally anonymous. If you scan that QR code, hopefully this poll should magically show up and change. Never heard of it, basic understanding. I'm an expert, intermediate. Okay, so we got some new people to MI. Great. And some people that have some understanding and maybe even a little bit more than that. Well, great. Okay. Seeing this change, I'll give it a minute. So most people intermediate, awesome. Okay. So, well, and I know for you, those of you that are not familiar with MI, this hopefully will still make sense, but I, again, would encourage you to go back and kind of learn a little bit more, maybe taking a basics class, and I can send out information on that as well. So while the core relational and kind of technical skills of MI, those are the same across settings, but how we apply it might be a little bit different between an inpatient and an outpatient environment. So in inpatient settings, MI is often used to plant seeds of change. This is especially true when motivation is low or when motivation is externally driven. So often in an inpatient setting, it's about stabilizing somebody because it has reached a crisis point and they are receiving care often against their will or because they're at a point that something has to happen. Maybe it's even been court ordered. So as a result, they might be in these really early stages of readiness, or we might call that pre-contemplation. The other thing to consider is that in an inpatient setting, they are in a controlled environment where substance use is restricted and medications are monitored. And for the most part, their basic needs are met and most of the triggers or barriers have been removed. But in inpatient settings, or excuse me, in outpatient settings, clients have more freedom. And so there is that risk of disengagement or relapse. They must really choose to keep showing up. And some of you mentioned that with some of the challenges that you see is like this engagement. How do we, keep them to show up? So it is important that a part of our work is to help them stay engaged. And again, as I spoke about, providing environments where they feel supported and they feel accepted. And I would even add, they feel hopeful about this journey and that we can help them navigate these real world stressors with some confidence. So MI has been found to work with people that experience co-occurring disorders. And there are some assumptions, I think, that often come up with co-occurring disorders in a sense that they might have little motivation to change their substance misuse or that they have wavering commitments to their abstinence. And I really wonder if it's just they have really strong motivations not to change or they have lack of confidence to do so. They're not unmotivated, but in some sense, they're really motivated to do what they do, or they're uncertain that they can make a change. And this is one of many areas where I think MI really shines. It's helping people build self-efficacy, this belief about their ability to make a change. And this is important because research has found there's a really strong association between increasing self-efficacy, that belief in myself, and my ability to change. So, as their belief in themselves goes up, they are more likely to change. They are more likely to remain in treatment. They are more likely to complete that treatment. The other thing that research shows is that while extrinsic motivation can help start that change and initiate it, it often fades if it's not internalized. And I'm not saying that extrinsic motivation is bad. So the threat of jail or the threat of losing their job, that can be very motivating for people. But if you're looking at this from a research perspective, intrinsic motivation is generally more effective for supporting long-term behavior change because it comes from them. It arises from their personal values, their interests, their goals. It's meaningful. There's that buy-in. And this is where, in MI, we're after this. We're after those whispers and that language about their desires to change, why they want to change, how they're going to change to build this intrinsic motivation for change that will get them through the cravings, that will help them find solutions, that will even, I guess, challenge them to persevere when it gets tough. So there is evidence and it has been found to be successful. And there are many ways to apply MI in treatment, but one that resonates with me the most is this approach that fosters autonomy and this sense of personal responsibility in their own change process, which can be really important for people who experience co-occurring conditions because they often feel defeated by their illness or disempowered or stigmatized by their family or community, or they've tried to make changes before and they've encountered a lot of barriers. And some of you put those in when we did that little Slido. And the skills of MI provide a way for them to see themselves in a different light and to see themselves being seen in a different light. And so it's this idea with MI that I acknowledge you carry wisdom, wisdom about your life, wisdom about what works best for you, and you know your why. So they are essentially reminded that they're in the driver's seat of their own life. And I think this is important because people change when they feel heard, not when they feel told. So giving advice without first understanding, that's a recipe for resistance. And maybe some of you even experience that in your work with people. So instead of telling them what to do because we are the experts, we create that environment where they can let their guard down, where they can feel heard, they can feel understood, they can feel accepted, and they can safely tell us what's alive inside of them because there is a space of acceptance and curiosity, and that just builds something different. And I won't go into this because we only have an hour, but my research is really going into how that creation of that safe environment, it actually changes us physiologically. It's not just a head thing or a heart thing, although it is very much those. It's also a physiological change that when we have these safe environments and these therapeutic relationships of collaboration and empowerment, something happens inside of our nervous system and the very biochemistry of our body. And what's amazing to me is that we now have some really cool tools to kind of quantify this and measure it, which to me is like, wow, we can actually measure the therapeutic alliance and what that's doing inside of us in terms of our nervous system regulation. So if you haven't already, guessed in the first 20 minutes, I love MI. I think there's a lot of like, yeah, I see your head nodding, Bob. It's like, yeah, I really do. Like it's a psychological process and a physiological one too. So that's why I think MI is really suited for co-occurring conditions because it doesn't assume that someone's ready or even willing to change, but that they might feel ambivalent about it. And we can create a space where they can start to pursue this in that safety without judgment or coercion, which usually shuts them down. Okay, so there's a little bit of research in case you're wondering, is she actually speaking truth? Well, I'll give you a few studies, and they happen to be relatively recent. So this was a study by Buckner, and it was a literature review of peer-reviewed clinical trials between 2020 and 2024. And RCTs, for those of you that aren't in the research world, are kind of the gold standard in research. So these RCTs examined MI interventions for individuals with co-occurring anxiety and substance use. And so they wanted to know if MI-based interventions improve treatment outcomes for those with co-occurring anxiety and substance use. And no surprise, right? This is why I'm showing it. They did find that yes, in fact, MI interventions were especially helpful when they were integrated with something like CBT, but these MI-based interventions were associated with like reduced substance use and decreased anxiety symptoms and even improved motivation. And so, yes, it was helpful. Here's another one that Santa Ana did in groups. So they ran an RCT with vets, so about 118 vets who met the criteria for co-occurring substance use disorder and major depressive disorder, who were receiving treatment in intensive outpatient settings. And so half participated in group MI and the other participated in a like a psychoeducational control. And they essentially wanted to know, does group MI impact engagement and treatment outcomes for this demographic group? And yes, the results were really promising. So, in their 3-month follow up, they found that compared to the controls, the individuals who participated in the group MI sessions, they were more engaged in their treatment. They attended 12-step groups more often. They reduced their alcohol use, including things like days binge drinking or just number of drinks consumed. So, yes, in this particular study, the group MI was especially effective. And then my last study, at least for right now, looks at weighing, and they did a meta analysis of 17 studies to look at the efficacy of MI in reducing substance use, but also with people who experience psychosis. And in this study, their goal was to understand whether MI works in this population and whether it works better or as a standalone treatment, or if they combined it with something like CBT. And so here's what they found. And I think this is really telling for this particular population. So in this study, they found that among those with co-occurring psychosis and substance use, MI itself did not significantly reduce substance use or their psychotic symptoms. But when it was embedded with broader therapeutic frameworks, the results were more promising. So in this one, the mixed MI studies, they did see a statistically significant reduction in substance use. And this finding really does suggest and highlight something that MI can be a really helpful tool with this population, but perhaps its strength really lies in being part of a comprehensive or integrated approach rather than just standalone. And I wanted to bring this in just to kind of show that, yeah, there are particular populations or circumstances where MI is still great, but there might be adaptations that we might want to consider. Especially if someone faces, cognitive challenges or they have more complex symptoms like hallucinations or delusions, which certainly could impact their insight. So, due to the amount of time today, I'm not going to go through these individually, but I will just say that these are the core skills of MI that we use to better understand someone's inner world, especially that inner world of ambivalence and that inner world of motivation. So we call them ORs, open-ended questions, affirmations, reflections, and summaries. And we continue to infuse these skills with that spirit of MI, which is partnership, acceptance, compassion, and empowerment. And that spirit is always coming from a space of curiosity and humility. And there are a few helpful modifications that I want to touch on in terms of the skills, and one happens to be around affirmations. So, with co occurring conditions, this is one of those modifications we might want to consider. So I'm guessing, like you, many of my clients or patients who come with co-occurring conditions, they have trauma injuries. So as I mentioned earlier, either as the root cause of their symptoms or as a consequence of them. Many of our patients or clients come carrying a lot of pain, a lot of shame, a lot of guilt. And I recently attended a presentation on compassion. I was telling Chelsea about this, but by a fellow mentee named Stephen Andrew, and he called these things cognitive whispers of trauma injuries. It's like this inner monologue that our patients or clients carry that says, I don't matter, I'm not lovable, the world cannot be trusted. And affirmations are a way for us to let them know that we see something in them that is worthy, valuable, and strong. So, affirmations intentionally recognize the strengths, efforts, and internal resources that somebody has. It helps them hear, maybe even for the first time, that they are doing something right. So, affirmations don't just communicate acceptance, they also offer hope hope that recovery is possible and also that they have the wisdom, the strength, and the abilities to make it happen. And so, if we recognize someone's strengths, values, or resiliency, we are actually touching on core aspects of their identity. And that can be a reminder that that identity isn't lost, that the wise, resilient, and creative person is still there. So, affirmations can really reframe how that person sees themselves because they are rooted in their actions and their values and not my opinion. It's all them, it's not me. So I might affirm them by saying something like, even though you relapsed, you came to this appointment today because you're not giving up. Or you're not sure where to start, but you know there's a way forward. You've made hard choices in the past, but now you're trying to make thoughtful ones again. That's what I'm saying. But what they're hearing is, I am someone who keeps going despite challenges. I am someone who still has values. I am someone who knows what to do. So affirmations can reinforce autonomy and they can also buffer against stigma and they can communicate acceptance and empowerment. So this is a new term in MI4. It used to be evocation, but now it's empowerment. So much of what happens in the name of helping is based on finding deficits. At least it has been for a long time. What the person is lacking or what they need or need to be told what to do. And the implicit message here is that I have what you need and I'm going to give it to you. Maybe it's my knowledge, my insight, my diagnoses, whatever it is. I'm the expert and I'm going to impart my knowledge, and somehow we just magically think they're going to change. We're going to be inspired to change. So, one way to view empowerment is to give the person something they don't already have: knowledge, skills, whatever it could be. And MI, we believe that they have the wisdom about themselves and they have good reasons for doing what they're doing. And our job is to understand them, and to get them talking about their reasons, their resources, their knowledge and expertise about changing, reminding them that they know what they need to do and they know how to go about doing it. Like, they know themselves best. They are the experts in their life. And this really shifts the focus from detecting faults to identifying those strengths and believing that people really do possess what they need for change. So, empowerment, that's kind of what it is, at least in MI. And it's also about envisioning, helping them entertain the possibility that life could be different, entertaining the idea that hope is still there. We all want to have power and control in our lives. We all want to love and be loved. We all want to have purpose and to belong. And as far as MI practices go, or as far as practices go, I think MI is really one of the best ones out there because it is relational as well as technical. So there's my selling point. All right, so one more Slido here. So I'm just curious, after I just talked about empowerment, I'm curious, how do you empower your clients? So I know we have a lot of experience in the room. What are you doing and how do you empower your clients or patients? Hopefully this works. I don't see anybody logged on. Yep, you scan the QR code and it should, or go to the, oh, great, we have someone coming on. Validating their lived experience. Yeah. Yep. Kind of honoring what they've been through. Affirmations. Yay. I love it. Keep them involved in the process and make sure they have a voice. Yeah. Yeah, thank you for sharing. Affirmations, identifying strengths. So some of you are already doing what I just talked about, asking about their goals and wants. Yeah, validating their own self-worth. Yeah. So many people come to us with guilt and shame, and this could be the first time they are seeing themselves in that light of value and worth. Thank you. Saying you can do that because you're strong enough for that. Yeah. Letting them make choices in the plan, giving them autonomy. Yeah. Reflection and goals. Wonderful. I think we have two more people typing. Turning negative into positives. Homelessness teaches many life skills. Gosh, doesn't it? Yeah. I like helping people identify those. Yeah. Treatment plans are their plans, not the clinicians. Yeah. Giving that autonomy. I'm seeing some of those themes here, which is actually one of the things we really try to emphasize in MI. So thank you for sharing all the ways that you empower your clients. All right. The other modification is to use more double-sided reflections. So double-sided reflections can be used to acknowledge both substance use and the mental health concern in a single kind of balanced statement. So this technique can also honor that complexity of a co-occurring condition and can be used with some skill to kind of guide that conversation or that client towards insight and hopefully change. So, in my example here, you use alcohol to feel more relaxed, and you also notice that your depression gets worse when you do. So, this is just one example. And if you notice in this reflection, it names both disorders and it kind of shows their interaction. And it ends with the client's own motivation for change. And that's important to put the behavior change or the desire or the reason or the need for change at the end of the reflection, because they're more likely to keep talking about change, and as if we reverse this, reflection here. So there is some research behind that we want to definitely try to end on the side of change because they're more likely to start talking more about that change as opposed to why alcohol helps them feel more relaxed. The other thing is that double-sided reflections can be used to move the conversation forward in a way that acknowledges that desire. So you use alcohol to feel more relaxed, and you also notice that your depression gets worse when you do, and you're looking for ways to manage your anxiety without it. So it's kind of moving that conversation and guiding them with insight, but not necessarily telling them what to do. Oh, I see there's something in here that's kind of stirring, and this is what you're thinking about. Or when panic hits, you reach for the pills and you want to break this cycle. Or missing your meds makes your symptoms worse and you want to find a schedule that works for you. So double-sided reflections can be really valuable and with this group too. And just a few other additions and micro skills. Again, those ORs that we talk about that can be really helpful. I think the first is to use really simple and clear language, especially with clients who experience co-occurring conditions and have more psychotic kind of disorders or psychotic features because they might struggle with really complex or abstract questions. So instead of asking, how does your drug use affect your mental health long term and short term? Like, okay, I gotta really think about that. What happens to your symptoms when you use? Like making it pretty clear and concise as much as possible. The other thing is that clients with co-occurring conditions, they might just need more time to process your questions or reflect on them and to formulate their thoughts. So I have to work on this myself is not to rush silence. Silence can be really powerful, especially like where I am in Alaska with certain populations and cultures, silence is a beautiful thing. And pausing and silence can actually be really therapeutic. And so this is something just to keep in mind. Many clients also come to us expecting some level of judgment or even control from the people they're seeing. And yet again, we can create environments of acceptance and that collaboration right out the gate. So perhaps when you're introducing yourself, you could say something like, I'd like to understand how alcohol and your mental health have affected your life. Mostly, I just want to listen and learn from you, from your point of view. We can also honor their autonomy and support them and their ability to make their own choices. Because again, they know themselves best. Even if it differs from what I think they should do, they're the experts in their life. And so you could honor their autonomy with reflections or affirmations. You get to decide what makes the most sense right now. You're trying to figure out what's right for you. And then we should reflect often. So in MI, there's a lot of research around reflections, and we're trying to get at least a 1-to-1 ratio of questions to reflections. Otherwise, question after question after question after question, it feels like an interview, and they start to shut down. They start to conceal rather than reveal. And so we're really trying to aim for that 1-to-1 ratio. And the more that we reflect on their experience, they're feeling more heard, and they actually get to hear themselves argue for change because we're becoming that mirror. The one thing I will add, though, is that with reflections, if you're working with someone who has distorted thinking or delusions, we want to really avoid reinforcing those delusional beliefs and really trying to keep that conversation focused on that change goal. All right, so how do we focus this conversation? Like, all right, give me some goods. I gotcha. Here we go. So, how do we begin the conversation with all of this in mind and all the complexities that we just kind of talked about? So, I think I have to click. Yeah. One strategy is to provide a circle menu, which is derived from MI. And this is a way of presenting an array of things that we could talk about. And it invites the clients to pick something they would like to focus on. And research has shown that circle menus, and this is an MI thing, but research has shown that they actually are pretty great for a lot of reasons. So, research shows that people are more likely to talk about sensitive topics when they're represented in circles. When those circles are represented randomly and with no hierarchy. And the thinking behind that is that the circle is the most universal, historical, and cross-cultural image that we have that represents protection, boundaries, and safety. People are also more likely to change when they are presented with a menu, when they have options. People are also more likely to change in any topic when they are the ones to pick the topic. Hey, there's something novel, like you just said earlier, rather than someone else picking it for them. when they have choice, when there's power and agency in their own life. And then finally, people are more likely to change when there is a focus on one topic rather than a lot, because that can feel overwhelming. So what does this look like? How could we do this? And so with clients who have co-occurring conditions, it's important to respect their autonomy and still help them see the fuller picture. So this circle menu that I've just made up here is this visual tool that lays out different areas that they might choose to focus on. So managing anxiety, reducing use, improving their sleep, taking their meds, whatever it could be. Rather than us deciding for them, we could invite them to pick the one that feels most urgent or meaningful to them. So you could say something like, many people find that their health or their symptoms are improved by making small changes. I've written a few areas down that have been shown to do this. Do any of these seem important, or which one seems most important to you right now? Or which one stands out to you as something you'd like to explore? Or is there something I missed that feels important for where you are right now? So let's just imagine they said, well, I want to work on my sleep. This could then open that opportunity for more exploration. So how do you think your sleep impacts your mental health or your substance use? You can be really creative in your questioning here and kind of gently reinforce both sides of their condition without overwhelming them. And it could be something like, for using sleep, you mentioned that when you quit drinking before, this helped your sleep. What was happening in your life at that time to make it possible? Or what ideas do you have about getting more sleep? So a circle menu really kind of supports this shared decision making, and it naturally opens that door to explore how mental health or substance use interacts together, where that intersection is, but it doesn't pressure them or overwhelm them based on your opinions. It's like, hey, we can use this to kind of create balance and choice. I also love Socratic reasoning. So this is another strategy that we can use in MI. And Socratic reasoning is kind of a questioning technique that helps clients reflect on their values and their beliefs and kind of their motivations through this guided discovery. So instead of giving advice or persuading them, the therapist could ask just thoughtful questions, open-ended questions that allow them to kind of explore their own logic and hopefully generate insight. And this approach is really helpful for people with co-occurring disorders who might feel ambivalent, or they're uncertain about change, or maybe kind of hold two contradictory thoughts about this. I don't want to take my meds, but I want to feel better, or, I want to quit using alcohol, but I'm concerned about my anxiety. So, I mean, you can kind of use Socratic reasoning as a way to kind of uncover some of the inconsistencies or help them resolve ambivalence. And again, I've given you just some examples here, and you'll have access to my slides. That's one way. I also love imagery, probably even more. So this would be, so yeah, I see. Baldwin's like, yep. So with people, this can get really heady. It's like, wait, but having a picture, at least for me, and I'm guessing many of you too, like this really helps kind of solidify it. So sticking with Socratic reasoning, we could add something like a stool metaphor. And this might look like, with that reasoning, if the stool represents recovery, or each leg supports your stability, what do you think would happen if one leg was missing? Or what other legs would you change or add in order to support you? And so this question kind of encourages the client to reason about, what would be the impact of not taking my meds or continuing to use or not going to my, participating in my recovery program. But we're not actually telling them what to do. It kind of keeps that conversation collaborative and not judgmental, with that aim of helping them build insight. So you could also have some fun with it, if these legs, if one of your legs needed super glue, to be more stable, what would that super glue represent? Or which one of these legs feels strongest? Which one needs more support? What would you do to help it be stronger? Have there been times when all three legs were really strong? What was different then? If you were going to work on a leg or a stool, where would you start? So you can kind of see where you can be really creative in your questions and still use that imagery to help kind of guide them. I also love, yeah, I do love images. I love the illness wellness continuum as well, because again, I think when you have an image, the world is your oyster. You can create so many cool questions and get their mind thinking more. kind of abstractly this way. So health and disease and recovery, they're often thought to be on this continuum or the spectrum. And we're kind of always moving between illness and wellness. And so on one end, illness is kind of like poor health. This can be, minor symptoms to more severe conditions or, more severe symptoms that are associated with that co-occurring condition. And then wellness is just this vitality, on the right. This is like optimal health. This is where you just feel alive. You've got physical, emotional, and social well-being. You've got energy. And when I teach this to my students, I tell them, look, I don't really care where someone is on in the spectrum. Like, I really don't care. What I care about most is the direction they're facing. So you could have someone all the way down here on the illness end, but they're taking steps to improve their health. They're taking their meds, they're going to therapy, they're eating better, they're connecting, you know, have healthy relationships. They're actually orienting towards wellness. Or you could have someone over here who's like relatively healthy, but their choices aren't. They're not taking meds, they're missing appointments, they're not participating in, self-care. So even though they're facing, or even though they're on the wellness side, they're orienting or kind of facing illness, and they're slipping backwards, even if they're okay right now. And I like this one because it shifts the focus from how healthy am I now to am I making choices that move me toward or away from my health goals? So rather than focusing only on abstinence or pathology, this could be a visual that helps clients explore kind of a broader spectrum of wellness. And we can help clients, kind of see themselves where they are and where they'd like to be without judgment. So, where do you see yourself right now on the spectrum? What direction are you facing? Where would you like to be? What would moving just a little bit more to the right or orienting just a little bit more towards health look like for you? And this also works pretty well with harm reduction because it kind of allows this flexibility for change. So, I mean, in terms of harm reduction, chances are the people you're seeing, no one's going to be totally on the left. I mean, presumably they'd be dead if they were. So, this gives you an opportunity to explore harm reduction. What's kept you from overdosing? What's kept you from killing yourself? What's kept you alive? And then we can use reflections and questions to explore themselves, help them explore themselves and maybe their behaviors. Things like, if full recovery feels too distant right now, what's a version of wellness that feels right or possible right now? I mean, we can come up with some really great affirmations here too. Presumably they're not dead. So you're not sure you can get all the way to wellness, but you might be open to small changes that help you feel more control. Or you feel stuck down here and this isn't where you want to be. You've thought about being over here, but you're not sure how to begin. You're managing a lot right now. And things are tough, but you haven't given up on the idea. You're walking towards wellness. It's been hard, but you've been pursuing it. So I like this tool. I think it gives us a lot of great ways to use questions and kind of meet someone where they are and really discover like their why and their wisdom and insight that they have to pursue health or orient towards it. Some more images and metaphor that I think are helpful. And this could be especially helpful for people who have difficulty naming what they're feeling or they're really tangential. So this could be the use of like a hot and cold. And I think this probably works best with like positive or negative symptoms. People that experience, maybe major depressive disorder or bipolar or schizophrenia. So hot could be those things that make the people feel like they're boiling inside or that they have tons of energy or actively hallucinating. And cold could be the symptoms that maybe make them feel frozen or numb or apathetic and withdrawn. So you could use questions here like, if your symptoms were a temperature, what would they be? What temperature do your symptoms feel like? If you were to change the thermostat on your symptoms, like what would you change it to? How would you go about changing that thermostat? You could even put it on a Likert scale, like between 0 and 10. If cold was down here and 10 was hot was up here, where would you rank yourself? Like, what would it mean for you to kind of like cool your symptoms down, or what temperature would feel right for you? So there's just another way to use imagery and something like a scaling question. And we do have scaling questions in MI. So this is pretty common. This is the importance and confidence ruler. And so if we were going to use something like this that is found in MI to explore importance and confidence, about their co-occurring condition, we could really kind of juxtapose them both somewhat against each other. So we could say something like, on a scale of 1 to 10, how important is it for you to feel less weighed down by depression? They might say a 7. Okay, on a scale of 1 to 10, how important is it for you to make a change in your drinking? Maybe they say a 5. And then you can explore those rankings. So managing your depression seems a lot more important right now. Why is that? Why is it a 7 and not a 6? Or, on that scale of 1 to 10, how confident are you that you could manage your depression without using substances? And so the idea here is to learn about what matters to them and why, to be curious about them as a person, and really to be humble in our understanding because they know themselves better than we do. They know what makes them work. They know what doesn't. They know what gets them out of bed. So scaling questions, if you're going to do these, the most important thing here is to kind of ask, like if they give you a 7 or an 8, ask why not a lower number? Because if we ask about why is it not a 4, chances are they're going to start talking about all the reasons, desires, needs, the ways they can and their abilities to make a change. It evokes change talk. So we're going to get them talking about the very reasons why it's important to do this and how they have the wisdom to make it happen. Now, I live in Alaska, as many of you have already known, or I told you this earlier. And so when I was teaching the importance confidence ruler, I remember scanning my audience and they were kind of like, huh, happened to be a very traditional indigenous group that I was working with. And I'm so glad I paused and said, some people like this kind of linear scale. What makes sense to you? And this is many years ago, and someone was like, I like circles. Yeah, of course, right? We just talked about circles. Yeah, I didn't see Baldwin's going, yeah. And so you could use a medicine wheel, or I'm just showing you like a season here. So some cultures don't prefer, the linear representations. And so you could be really creative here. When you think about your health, what season do you find yourself in? Where would you like to be? What would it mean to move from winter to spring? How does your mental health or substance use impact the season that you find yourself in? And it's really interesting about seasons because most people, if you talk about spring, it's like new beginnings. If you talk about summer, it's like adventure. Fall is often like letting go and acceptance. And the reason is, I think about if trees didn't lose their leaves in the fall, they would die if you're in a place like Alaska because of the weight of snow. So fall is often letting go and acceptance. Winter might be the time to like, hibernate or rest or recover. So you could be really, creative in your questioning and insight here with this. Sticking with circles, we could also represent them like in a table. We could do addition and subtraction approaches to kind of help them better understand what works for them. So it could be questions like, what could you add to your routine or take away from it that would help support your recovery or mental health? And again, this is kind of hierarchical, but I do like circles and lots of options and choice. They can kind of see their thoughts externally, and that image sometimes can be really helpful. And again, circles are representing, safety, boundaries, and protection. So if we can, that even unconsciously can be something that they can use. Now, I'll be honest, I am not trained in ACT. So if you are trained in ACT, maybe you've seen this before and can use it. Apologize, you shaking your head too. So I went to a training and someone mentioned this and I thought, oh my gosh, this is beautiful. This could so be applied to, yeah, we're getting some heads like, yes, it is. So I just want to like humbly say I'm not, like an ACT provider, but when I learned it, I thought, yep, that makes total sense. So correct me if I'm wrong, but it seems that this ACT matrix is a tool that can help people like look at what's happening inside of them, their thoughts, their feelings, and then also what's happening outside of them, those actions. So inside reflection, outside reflection. And then with co-occurring conditions, it can help kind of show their thoughts or feelings and what might pull someone towards unhelpful behaviors like using substances, or, kind of move them towards what really matters to them, like their health or relationships. And so when I first saw this, I thought, this could be another visual map that with the skills and techniques of MI, this could be really helpful for people to notice and see those patterns and then make choices that kind of line up with their values instead of being stuck in old cycles. So if you're a ACT wizard, here you go. Here's another way to use it and from that MI lens. And then my final strategy here, or just thing to consider, would be values. And so MI does have, and if you Google, there's free PDFs on MI values cards that you can print off. And there's also a values sort activity. And I probably should have included this as attachment, so forgive me. But you can Google it and it's free. And if you, maybe I'll send it actually to you, Jen and Chelsea, so that they can have it right away. So values, big one in MI. So we often assume that everyone who comes to us is ready to talk to us, uh, but that might not be the case. And we can build engagement and rapport with them by finding out what matters to them. And I think this is where values really shine. So this value sort is an MI thing. And if you look at how you do it, often it'll start with a question. And in terms of, co-occurring conditions, it could be something like, sometimes when things feel chaotic or overwhelming, it helps to take a step back and look at what really matters to you. Would it be okay with you, or would you like to explore your values and what's important to you? Or maybe we're just meeting them and it's like, we're just beginning our work together and I would like to learn more about you as a person and what you value. Would that be okay? And the emphasis here is just it's discovery. It's not about judgment or setting goals. It's about curiosity and their own self-discovery. And so you would do the sort. You would print off the values cards or whatever method you want to use, and then you could put them like in two columns. And one column could be, what's important to me and what's not important to me. And you just have them rank their values based on those cards. And this is a really great opportunity for them to for you to understand them, and for them maybe to even kind of reflect on those things that are deeply meaningful, those intrinsic things that will help that intrinsic motivation for change to be sustainable, getting them through those cravings, getting them through those tough times. And again, you could have a lot of really rich questions and reflections off of this. I see you put your family and growth as most important. What's important about these values? What does it look like when this value is strong in your life? Which one of these right now feels hardest to live out? You could really explore behaviors and values where they might not intersect, but you could do it without blame. Like, oh, I'm wondering how your situation with, meth lines up with your values here. Like, what do you notice? So you can also, kind of evoke questions that kind of show this kind of discrepancy. So, what would need to change in your life for you to live more in line with your values? How does your mental health and drug use affect your ability to show up for your family? So there's just a lot of opportunities here to kind of frame that behavior change as a way to move closer to what matters to them, not as punishment or obligation, but moving closer to that core identity of who they are and that value they hold. All right, and so my last, I think it's actually one of my last slides here. Look at me, I'm on time. Is this a study? Just to say, yes, I hopefully gave you some ideas. And if you're new to MI, I hope I excited you about it, but there's so much more here to it. And I would encourage you to kind of learn and get back to those basics. But I did want to just emphasize that MI can be beneficial with co-occurring conditions. And current research, this is 2025, y'all, it says that, yeah, this is helpful, and that it's best to be used as an integrated approach. So this was a recent study that looked at MI with co-occurring conditions, and they did a systematic review of 8 randomized control trials of people who did experience co-occurring conditions, and here's what they found. So basically, the majority of the studies show that there is clear improvement in outcomes, like most outcomes. So things like symptoms, medication compliance, relapse, substance use, and just like general functioning. And their final recommendations here is that MI should be adapted to the stage of change where someone is, and consider how their comorbidities, their environment, their, social context kind of factors into their symptoms and how they're functioning and how they understand what's going on. And, the thing here is that integrated approaches generally tend to improve outcomes more favorably. MI is something we can bring into it, and we could, bring it into things like MAT or CBT or peer support or ACT. And we're using the skills, the techniques, and that kind of relational aspect as we're listening for that change talk and helping guide that conversation towards change. So again, I think MI is lovely and amazing, and we do see use with things like co-occurring conditions. And I would encourage you to say, how could you fit something like MI into your practices already, and maybe use some of the imagery or those things that I just talked about. So here, if we're gonna like summarize MI, isn't this cute? I made this. A little boat here. Here's kind of like our change talk. Here's the skills. Here's our spirit. And then this is kind of the four tasks, which I didn't get into today. So here's my last slide. Quote by Helen Keller: "Better to be blind and see with your heart than to have two good eyes and see nothing." So thank you so much for your time. I'm like right on time, and I think we have a few minutes here